Thank you. I'm going to talk a little bit about the latest safety bundle, as well as implications for neuraxial anesthesia in regard to VTE prophylaxis. I have no more financial disclosures. Objectives, kind of a roadmap of what I want to do with this talk is talk about the impact of venous thromboembolism on maternal morbidity and mortality, go over some of the elements of the VTE safety bundle, and then go into detail regarding recommendations from SOAP regarding neuraxial techniques in OB patients anticoagulated. So to begin with, I know we've seen a lot of mortality. As you can see, I don't have the most recent graph. The US mortality has gone up even farther than 22 per 100,000 to 24 now. But I think the interesting thing on this graph is, although the red line is the US rate, the blue line is the California rate. And you know, it's not a randomized controlled study. I can't completely say cause and effect, but one thing that California has been leading in is putting in these various safety bundles, from hemorrhage bundles to preeclampsia bundles, now a VTE bundle. There's also a cardiovascular bundle. And I just want to sort of impress upon you the potential effect of putting these bundles in place. Okay. So let's talk a little bit about the California experience. This is going back to 2002 to 2004. A review committee was put together to do a chart review of maternal deaths in the state of California during these years, and look at maternal mortality not as just one entity, but as a variety of entities, from cardiovascular disease, preeclampsia, hemorrhage, and thromboembolism. And then in doing the chart review, tried to determine what are the factors that may have led to this mortality. So in blue, you can see sort of a delayed response to warning signs, hence the prior talk, ineffective care, misdiagnosis, no continuity of care, and didn't get the right people there to consult in time. And you can see this is pretty uniform across any cause of maternal mortality. VTE is no exception to that. So the committee then went through and tried to determine, had the correct diagnosis been obtained earlier, had the right resources been in place, had protocols been there, what is the chance that we could have altered outcome, meaning saved the life of this mother? And you can see that right under obstetric hemorrhage is VTE. And in over half those California cases that were reviewed, they came up with the idea there was a strong to good chance that that mother could have been saved. And this was sort of the impetus for doing these safety bundles. Okay. So now let's talk specifically about thromboembolism. These are the rates of thromboembolic events in the US in a retrospective study of about 2.5 million vaginal deliveries. And you can see as we go from 2006 up to 2012, every type of thromboembolic event is going up. Not only is the event itself going up per 100,000, but the rate, which you see on the right-hand graph, in general, has also been going up. That was vaginal delivery. How about cesarean section? So we have a meta-analysis of a variety of studies of thromboembolic events comparing relative risk of cesarean section and vaginal delivery. And you can see the relative risk is almost threefold of having a VTE following a cesarean section compared to a vaginal delivery. Okay? So if you were to remember just a few things about this talk, there's going to be about 3 to 4. So this is one, is that the CMQCC has a website, and they have their safety bundles that have been mentioned previously. You see the VTE in pregnancy safety bundle I have forthcoming. I contacted Elliot Main yesterday, who's the sort of lead on this CMQCC effort. It has now been approved by the California Department of Public Health. He thought it might even be on the site, but I just checked a few minutes ago. It's still not quite up. But I encourage you, even if you're not from California, to take a look at this. What these safety bundles are they're not new guidelines necessarily. They're taking existing guidelines and trying to bring them together in a very understandable manner that you can implement at your institution to make things safer. Okay. So in addition to the California effort, there are safety bundles from ACOG's Safe Motherhood initiative that you can also look up. And starting in 2016, there was a VTE bundle by the National Partnership for Maternal Safety, and that's their website there also. So this is more of a national effort than the California effort. There's slight differences and similarities between the two. And you can see this national effort has a variety of safety bundles, and the second one there is the Thromboembolism bundle. Okay, so this was published in 2016 in ANA, just sort of a summary of the National Partnership's consensus bundle on VTE. And really their goal is to try to have this safety bundle adopted into every birthing facility in the US. And again, it's nothing new, it's just combining existing recommendations. And part of the problem is you have different recommendations from ACOG, from the Royal College in Great Britain, from the American Academy of Chest Physicians, and they've done their best to sort of put these together for you in a usable package. All right. It's a very lofty goal because as you see, looking at annual birth volumes in US hospitals, we have the number of hospitals on the y-axis and then their annual birth rate along the x-axis. And the vast majority of hospitals in the US have very small labor and delivery wards. But it is very important for these safety bundles to get to them because they're doing a significant amount of the US delivery rate. So just to go over the general components from sort of a 10,000-foot view of the National Partnership Safety Bundle, they have Readiness, and they really want to bring this to, initial antepartum visits, outpatient prenatal care, thinking about hospitalization postpartum, and even after they go home, what's going to happen, and just have everything in place. Recognition and prevention. A lot of this focuses around education, not just of the patient, but of the healthcare providers themselves, understanding the risk assessment tools and current recommendations. And this is the part that in the forthcoming slides we're going to go into a little bit more detail, but looking at the recommendations, not just for mechanical thromboprophylaxis, but also prophylactic and therapeutic pharmacologic anticoagulation. Having sort of standardized recommendations to this approach in light of the need to do neuraxial anesthesia in the obstetric population. And then finally, the fourth component is reporting and systems learning. And this is sort of critical in that if you roll out a safety bundle and you're not following up on how frequently you're actually following it, you don't know if your outcomes are not changing because it's not working for you or because you're not following it. So it's really important to monitor your progress, have metrics, and see how you can improve it in an almost iterative fashion. Okay. So back to this National Partnership consensus bundle. So sort of the reason this came out is previously in the US, what was happening was what we were doing for prophylaxis was women with certain risk factors such as prior thromboembolic events, thrombophilias, and a family history were getting some sort of pharmacologic prophylaxis, and following cesarean, the standard was just mechanical prophylaxis. But with the new safety bundles and sort of bringing these guidelines forward, there's going to be a lot more people receiving pharmacologic prophylaxis, if not therapeutic. Okay? So just to give you an example here, this is from ACOG, and looking at who's going to get anticoagulation in the antepartum period, even at their first prenatal visit. So people who would get a treatment dose of either low molecular weight heparin or unfractionated heparin, multiple VTE episodes, high-risk thrombophilias, or VTE with acquired thrombophilia. And the next slide will go over what's high risk and low risk for thrombophilias. Prophylactics, if they get a VTE with pregnancy or oral contraceptives, if they have low-risk thrombophilias, family history with high-risk thrombophilias, so on, and then no treatment you can see at the bottom there. So how does ACOG differentiate the thrombophilias? So low risk is heterozygosity of either factor V Leiden or prothrombin gene mutation, protein C or protein S deficiency. The high risk is the homozygosity of the factor V or the prothrombin gene mutation, as well as an antithrombin 3 deficiency. Right? They define what they mean by family history and acquired thrombophilia. Okay. The other thing that you're going to see is the new national safety bundle being put forward is that for hospitalized patients, obstetric patients, who are on the ward for greater than 72 hours, they're going to get daily thromboprophylaxis with low molecular weight heparin, say 40 Q-day, or twice daily unfractionated heparin. This would only be different if they were at high risk of bleeding or imminent childbirth, and then they would decrease it to 5,000 units BID of unfractionated heparin. Okay. I put this slide up. I'm not sure if you'll be able to read it or not, but the point of this slide is sort of in that middle section. You can go down the left-hand column until you see prophylactic unfractionated heparin. And you can see that the prophylactic dosing being recommended by ACOG changes by the trimester, right? So in the first trimester, it's 5,000 to 7,500. Second trimester, 7,500 to 10,000. And in the third trimester, it's 10,000 every 12 hours. So this can make it kind of difficult when you're thinking about neuraxial anesthesia or analgesia. But luckily, SOAP put together a VTE Task Force that just came out officially this past March, or I guess this month. And the reason they did this is sort of what I've alluded to. So you have patients who are going to be receiving more prophylaxis. You have thromboprophylactic doses of unfractionated heparin that can be quite high, 10,000 BID. And the other thing I think most of you are aware, but maybe not, is that the first 3 editions of the ASRA guidelines said that if you were just on 5,000 units sub-Q BID of unfractionated heparin, there really wasn't any contraindication to proceeding with neuraxial. But with the new edition of the guidelines, which are what you would see on your PDF if you download the ASRA app, and they haven't been validated even though this PDF application has been out for over a year now, is that you should wait 4 to 6 hours after even 5,000 sub-Q BID of unfractionated heparin. So because of this, there's a lot of confusion as a clinician as to exactly what you should be doing in light of these changes. So before we go to the recommendations, I think it's important to look at the difference in unfractionated heparin and low molecular weight heparin, whether you're pregnant or not pregnant. So on the left-hand side is unfractionated heparin, and I believe these are 27-week pregnant women, so just a little past mid-gestation. And after their dose of unfractionated heparin, you can see when it peaks, the solid circles are non-pregnant and the open circles are pregnant. And you can see that they both peak at right around 2 hours, but the peak level of the pregnant woman getting the same dose is about half that of a non-pregnant woman. And another way to think about it is that if you had a non-pregnant person, if you go out about 6 hours, the level at 6 hours kind of coincides with the level at 2 hours or the peak dose of a pregnant person, right? So you see this sort of big difference between pregnancy and non-pregnancy. And so there's two ways of thinking about this. One is that, potentially we could use different guidelines for neuraxial because the volume of distribution and the clearance is very different in pregnancy. And the other is you can also begin to see why the obstetrician may not want to be using 5,000 BID because it's not reaching anywhere near the levels that it would in a non-pregnant person, right? And so you can kind of see why they might be upping it with the trimester. And we have just a sort of similar pattern if we move over to the low molecular weight heparin and anti-10A activity. And you can just see the top curve is non-pregnant, and as you progress through the trimesters, the peak activity decreases despite the same dosing. Okay. So what are the antepartum recommendations from SOAP's VTE Task Force? One is that you have some sort of standardized protocol for thromboprophylaxis that is easily accessible, and that potentially you even put in alerts in your electronic medical record to tip people off if one of these patients is receiving pharmaceutical thromboprophylaxis. Having early pre-delivery anesthesia consultation and planning with the obstetricians. Having anesthesia notified and good communication whenever a patient's status changes, right? And then adoption of sort of a plan or regime that tries to facilitate neuraxial procedures into the planning of this anticoagulation and VTE prophylaxis. And they also advocate for patient education and explaining to them why what's being done is being done because of their potential risk of imminent delivery or bleeding or so on. Okay. This is the next part that I would just want you to remember that this document exists, and I think they've done an amazing job with these clinical flowcharts. Now, these are not in any way like legally binding documents. You have to do this. This is just to help facilitate clinical decision making when you have more urgent need for neuroaxial procedures on OB and you have an anticoagulated patient. And I recommend, I printed these out. These are posted on like refrigerators in the lounge or on boards or wherever, just so people have good access to it. So this is for unfractionated heparin. So if we go across the top just quickly, you can see 5,000 twice or 3 times daily. Has it been more than 4 to 6 hours? If the answer is yes, it's easy. You can certainly do any sort of neuroaxial spinal or epidural. And that's the same as the ASRA guidelines. Now, if it's no, it hasn't been that long, then is it easy for you to get a PTT or factor 10A? And if you can get it back quick and it's fine, then yes, you could proceed, right? If the answer is no, you kind of go to that middle where you have to sort of balance the risk-benefit of what you want to do based on your clinical assessment of the patient and sort of understanding of what happens with unfractionated heparin in pregnancy. We'll go back to the top, sort of that intermediate 7,500 or 10,000 units. If it's been more than 12 hours, no problem. You should probably still check a PTT if you can, and you can proceed with neuraxial. If it hasn't been 12 hours, you could try to check a PTT, and then based on that and your clinical judgment, decide whether or not you're going to proceed. And on the far right, we have the very high dose, 10,000 units twice a day. And if it's been more than a day, more than 24 hours, right, then you could proceed after checking a PTT. So let's go on to the low molecular weight heparin. This is their flow diagram for that to help with clinical decision making. So on the left, we have the low dose, which is either 40 milligrams sub-Q once daily or 30 twice daily. And very similar to ASRA, if it's greater than 12 hours, you can proceed. If it's not, you're going to have to use your clinical assessment and significantly think about not proceeding, but balanced with the clinical situation. I'm going to go all the way over to the right where it says high dose. So this is 1 milligram per kilo twice daily, or 1.5 milligram per kilo once daily. We're using the 24 hours there, just like ASRA. If it's been more than a day, they didn't get that dose, you could proceed. If it hasn't, you'll have to use your judgment. And anything in between those two with low molecular weight heparin, really not a lot of data to guide. Okay. So what about postpartum? So current recommendations are following vaginal delivery, early mobilization, avoiding dehydration, and postpartum thromboprophylaxis with either unfractionated or low molecular weight is really based on risk assessment. Do they have a history of VTE? Were they already receiving heparin for a risk factor? And if so, with the vaginal delivery, they would be put back on thromboprophylaxis. For cesarean delivery, recommendations are sequential compression devices perioperatively and postpartum for everybody having a cesarean delivery. And then the need for prophylaxis is on risk assessment. And that's kind of the next slide. Now, I'm going to give you one set of major and minor risk factors, but know that they're different between, the Royal College of Obstetricians and Gynecology, the chest physicians, and the California Maternal Care Collaborative. And so I'm just kind of giving you a flavor because depending on what bundle is chosen, they're going to be a little different, but the bottom line is you're going to have a lot more people post-cesarean getting some sort of prophylactic heparin. So the idea is if they have one major or two or more minor risk factors, they should get some sort of pharmacologic prophylaxis. To give you an example of minor risk factors, BMI greater than 30, smoking, it was an emergent cesarean, they're preeclamptic, you get an idea that you can get to 2 minor risk factors pretty quick in a lot of patients, right? Major risk factors, previous VTE, the bed rest, but I think one that happens not infrequently is a postpartum hemorrhage greater than 1,000 mils with surgery, right? So if you needed a blood transfusion or you've had significant hemorrhage, you already have a major risk factor. Now again, these are going to change a little bit in the way CMQCC does them or the Royal College, but the bottom line is that you're going to see more prophylaxis. So, just to review the recommendations from SOAP's task force, for sub-Q unfractionated heparin thromboprophylaxis, you would wait an hour after any spinal or epidural needle placement or catheter removal before initiating it. They do say it's reasonable to maintain indwelling catheters on 5,000 units BID, and catheter removal should be 4 to 6 hours after the unfractionated dose, very similar to ASRA. If you're using IV unfractionated heparin, don't give the dose until at least an hour after the block. For a low dose enoxaparin, again, 30 BID or 40 Q day, you want to wait 12 hours after a spinal or an epidural needle placement before giving that dose, and you want to wait more than 4 hours after a catheter removal. That mirrors ASRA guidelines also. SOAP's task force does say it's reasonable to maintain indwelling catheters with low dose, low molecular weight heparin, and catheter removal should be greater than 12 hours. And just a few more. For the high dose, low molecular weight heparin, you want to wait 24 hours rather than 12 after the procedure and 4 hours after a catheter removal. One thing to think about in consultation with your obstetric colleagues is for select circumstances, there may be benefit to bridging with the prophylactic unfractionated heparin instead of low molecular weight in certain circumstances, and I have those listed there. It's mainly risk of bleeding or needing to go back to the OR, so on like that. And the other thing to think about is, although we're all in agreement about benefits of multimodal analgesia, you may want to consider holding NSAIDs with indwelling catheters in place if you're using heparin or low molecular weight heparin in addition. Okay. So, I mean, that's really the end of the talk. I really just wanted to go through those changes with you and the guidelines. And again, most importantly, you can access either one of these sites and get their safety bundles that have all the guidelines that I showed you. The SOAP manuscript from their task force is out. Those flowcharts are really excellent, and I encourage you to download them. So thank you.